Bismillah ar-Rahman ar-Rahim. This is the last session, and we have good news for the attendee. We have a discount. We'll have only 2 talks for the last session. We'll start by Professor Dr. Ahmed Damati for one of the most important common challenges for heart failure management, atrial fibrillation. When to consider ablation.
مساء الخير الاساتذه والزملاء. بشكر دكتور مجدي على الدعوه الكريمه، وان شاء الله ال10 دقائق الجايين هنcover an important topic which is atrial fibrillation and heart failure and when to consider AF ablation. So as we all know, AF and heart failure commonly coexist, and they have a complex, incompletely understood interrelationship. AF is independently associated with a 2-fold increased risk of all-cause mortality in women and 1.5-fold increase in men. A minority of these deaths are related to stroke, while sudden cardiac death and death from progressive heart failure are more frequent. In my talk, I'm gonna address these points. What's the dogma of AF management? What's the challenging the dogma in the general population? What does the recent data say? What about challenging the dogma in patients with heart failure? Are all heart failure patients the same? And then we will talk about the guidelines, where do we stand? So the AF dogma is rhythm control is not better than rate control in terms of mortality or major adverse cardiac events. And its only benefit is because of symptom control, better symptom control. So this dogma originated from the time-honored AFFIRM study, which was published back in 2002 in the New England Journal of Medicine. And it studied about 4,000 patients, randomizing them to rate control strategy versus a rhythm control strategy. And they looked at the composite endpoint of death, disabling stroke, major bleed, or cardiac arrest, and they found no difference. But the problem is the AFFIRM study had some major limitations. So the rhythm control was by the means of drugs. Atrial fibrillation ablation was still in its crib. Rhythm was only maintained in about 60% of patients, and the drugs used were neither effective nor safe. So recent data are trying to challenge this dogma, and we're trying to change it. So in terms of challenging this dogma in the general population, we have the important trial, the CABANA trial, which is a trial of catheter ablation as a rhythm control strategy, a sole rhythm control strategy, versus antiarrhythmic drugs, whether it's used for a rhythm control or rate control. So the CABANA study studied about 2,000 patients, perhaps a little bit more, and it randomized into 2 groups, the ablation arm and the drug therapy arm, and it followed them along for about 4 years. Mostly patients were either paroxysmal or persistent in both limbs. Unfortunately, the CABANA study failed the challenge. So there was no difference in the primary endpoint, which was again the death, disabling stroke, serious bleeding, or cardiac arrest, which means that in the general population, the dogma is still valid and we are still in the square one. Rhythm control only offer better symptom relief. So what about challenging this dogma in the heart failure population? So this study is the AATAC study, which studied ablation as a rhythm control strategy versus amiodarone as another rhythm control strategies. But that was in patients with persistent atrial fibrillation in the heart failure population. All these patients had an implantable device. So they randomized about 200 patients or so who had persistent AF. All of them had either a dual ICD or a CRT defibrillator. They were NYHA class, either 2 or 3, and the rejection fraction was less than 40%. They were randomized into 2 groups and followed along for about 24 months. And the primary endpoint was looking at the left ventricular ejection fraction, the distance the patient can walk in a 6-minute walk test, and the score that he gets in the Minnesota Living with Heart Failure questionnaire. So in terms of AF recurrence, AF ablation was significantly better when it's compared to amiodarone. Bear in mind that amiodarone is the strongest medication that we have for rhythm control. So the procedure is better than our strongest medication. So what about the primary endpoint? The primary endpoint was significant better improvement in the left ventricular ejection fraction, significant better distance that the patient can walk, as well as a lower score in the Minnesota Living with Heart Failure questionnaire. So catheter ablation decreases the recurrence of atrial fibrillation, and this directly leads to a better quality of life and a better ejection fraction. So the question is, does this transfer into one of the hardest endpoints? Does this improve mortality? Does it improve reduces the MACE? And this question was answered in the Castle AF study. So again, 3,000 patients were screened. About 400 patients were randomized into an ablation arm or conventional therapy with drug therapy. And these patients were patients with symptomatic heart failure, NYHA class 2, 3, or 4. They had paroxysmal or persistent atrial fibrillation, and their left ventricular ejection fraction was less than 35. The primary endpoint in this study was all-cause mortality or worsening of heart failure, so a strong endpoint. So these are the baseline characteristics of these patients. I just want to point out that the mean ejection fraction or the median ejection fraction of this study population was comparable, and it was in the range of 30% or so. So patient with heart failure and reduced ejection fraction. So what was the primary endpoint? Death or hospitalization from worsening heart failure, and it was significantly better in the ablation group. So in the heart failure population, you have better hard outcomes compared to medical treatment. So looking at the mortality, there was no difference, and obviously the difference was driven by less hospitalization. So the authors of this publication concluded that catheter ablation for atrial fibrillation in patients with heart failure was associated with a significantly lower rate of a composite endpoint of death from any cause or hospitalization for worsening of heart failure. And that was better than medical treatment. So heart failure patients, are they all the same? And we have two studies that could answer this question. So this is a subgroup analysis from the Cabana study that was a basically negative study. They looked at patients with heart failure. But these patients were clinically in heart failure, so they had NYHA class 2 or 3, but most of them had an ejection fraction, like 80% of them had an ejection fraction that was more than 50%. So you could say that this is sort of heart failure with preserved ejection fraction. About 700 patients of the 4,000 patients of the Cabana study. So what did they find? They find that with ablation, the AF recurrence is significantly lower. The primary endpoint, which was a MACE endpoint, was less in patients who had an ablation procedure. So again, a repetition of the notion that perhaps in a certain patient population, namely heart failure, you might be better off with a catheter ablation procedure when compared to medical treatment. So what about patients with advanced heart failure? So the answer is in the AMICA study. So the AMICA study randomized patients who had sicker hearts, so a more sick population of people. The mean ejection fraction in this patient population was about 25% or so. They will randomize them into catheter ablation again versus the best medical therapy, whether this best medical therapy is drug therapy for rate control or whether it is for rhythm control. And this was left for the discretion of the treating physician. So again, these patients were followed for 12 months or so, and they looked at their ejection fraction at the end of the study. And we can see that the ejection fraction improved in both patient groups. But what is important is this improve was no different between those who were randomized to catheter ablation versus those who were randomized to the medical treatment arm. Again, looking at the walking distance or the Minnesota Living with Heart Failure questionnaire or the Pro-BNP, there was improvement in both groups, but the change was not significant. So perhaps in a sicker patient population, restoring sinus rhythm with an ablation procedure might not be as helpful as a patient with a sort of a more preserved ejection fraction. So in view of this, what does the guideline tell us? So the far left of the screen is about a patient who has a preserved ejection fraction and is not presenting with heart failure, so just atrial fibrillation. So as you can see, you take the patient choice, you tell him about the pros and cons of the procedure, and then you offer an ablation procedure. But when you do that in the general population, it's a class 2A indication. And only when the patient fails medical treatment, he gets to a class 1 indication. On the other hand, if you look to the right side of the screen, in patients with paroxysmal or persistent atrial fibrillation, presenting with heart failure manifestations, catheter ablation can be offered after explaining the pros and cons of the procedure from the get-go as a class 1 indication, based on the evidence that there is mortality and MACE benefit in this patient population. And of course, if this patient fails a drug therapy, he can be offered an ablation procedure. So my take-home message is atrial fibrillation and heart failure very commonly coexist. Medical treatment and catheter ablation remains to be the possible alternative of therapy. There is a growing evidence that praises the future role of catheter ablation in maintaining normal sinus rhythm, particularly in the heart failure population, and therapy should be tailored for each patient according to the heart failure status and the patient preference. And thank you very much.
Ahmed, thank you very much for a very important topic, very elegant talk. Any question from the floor? Yes.
Thank you, Dr. Ahmed, as usual, and it's very elegant presentation. I have a simple question about heart failure with preserved ejection fraction. Is there any studies that recommend ablation for AF ablation for patients with heart failure with preserved, not with reduced?
Yeah, I guess the Cabana study would categorize these group of patients. So they had, in the Cabana study, about 80% of the heart failure studied had preserved ejection fraction. And these patients not only had symptom relief, but they also had mortality and MACE reduction.
They get some benefit from ablation.
Yeah, exactly. Okay. So the only group that there is no clear benefit from the AFib ablation procedure is the group with really advanced heart failure. So ejection fraction sort of less than 30 or so.
شكرا دكتور احمد. في بس سؤال، امتى يبقى في الهارت فيلير واي اف يبقى الابليشن كونتر انديكيتد؟ يعني امتى اقدرش اعمله؟ ولا هو كده فريلي في اي حاله ممكن اعمله؟
بص حضرتك، هو مش كونترا انديكيتد بالمعنى المفهوم طبعا، اكسبت لو كان العيان بقى هيمودايناميكالي كومبرومايزد او كذا، بس في فاكتورز تقلل السكسس ريت. يعني ejection fraction less than 30 decreases the success rate. Left atrium that is more than 55 millimeter would reduce the success rate as well. So a very long history, very long standing atrial fibrillation would reduce the success rate of a procedure.
I thought your presentation was outstanding. Thank you very much. I have a question about the guidelines in heart failure patients with atrial fibrillation ablation. I was actually at the University of Utah. We were the major enrolling center for the CASTLE AF study. And one of the prerequisites for the study was failing antiarrhythmic therapy. Why do you think that in heart failure patients, the guidelines gave a class 1 indication to go to ablation without failing antiarrhythmic therapy, although the study needed them to fail antiarrhythmic therapy before ablation, and then it gives them class 2A if they fail antiarrhythmic therapy, as opposed to the opposite?
Yeah, that's a very important question. I would think there is not only the Castle AF study, but there is sort of a push towards AF ablation because physicians are getting familiar with the procedure and the success rate is sort of better than before. And it's not only the Castle AF, perhaps the AA-TAC study and some other smaller studies pushed the direction toward sort of a more liberate approach when it comes to AF ablation. But I understand your point. It's very well taken. It's a good chance to tell you that our practice here in this country, partly because of the limited resources, that we still offer medical treatment first before AF ablation procedure, except for a really young patient with a really paroxysmal frequent attacks, small left atrium, who really doesn't want to be on medical treatment. That's the only spectrum of patient that we offer ablation from the get-go.
Thank you so much.
I have a question, please. Thanks, Dr. Ahmed, for this comprehensive talk. I have a question regarding the presence of significant mitral regurg. It may change decision regarding AF ablation or not?
Not really. Up to moderate mitral regurgitation is commonly faced in AF, and we do ablation regardless its presence. When it comes to severe mitral regurgitation, we have to think first about the etiology. Obviously, if the etiology is fixable, like if it's valvular or some other problem or prolapse or something, it has to be fixed before the atrial fibrillation is addressed.
But if secondary with severe mitral regurg, it's
not an absolute contraindication. It's not an absolute contraindication, but it's always a matter of weighing the success of the procedure, in terms of the risk and everything, and each patient has to be treated individually.
Thank you.
Now last, but definitely not the least, I have the pleasure to introduce my friend and colleague and bro, if I can say, Dr. Hatem Suleiman. Dr. Hatem Suleiman this is not the first presentation for him in this conference, but Hatem is a master of this technique, and he's going to tell us about the advanced hemodynamic assessment in critical care patients by bedside ultrasound. Hatem is leading this program in Hereford Hospital, London, and actually is teaching the world this technique, and I'm very happy to introduce him today.
Thank you very much, dear Hani. It's a great pleasure to be here and honor to be with you, and thanks for the kind introduction. So in this presentation, I'm going to build upon what we discussed in the last one. So the last presentation was lung ultrasound. So this is an approach to show you how I perform integrated ultrasound to assess patients' hemodynamics at the bedside. So the concept of performing targeted ultrasound at the bedside in a short period is the concept of point-of-care ultrasound. So this is actually the major approach that I will take in the presentation, and I will discuss the rationale. I will go through a very short case presentation to show you how we do it, and I will go through the challenges, and I will finish by the take-home messages. So point-of-care ultrasound is basically performing point-of-care echocardiography, lung ultrasound, and the additional new modality, which is systemic venous congestion assessment with ultrasound at the bedside to answer specific clinical questions in a short period, which makes it different from the comprehensive, thorough echocardiographic evaluation. And that's the traditional split between basic point-of-care ultrasound, which has been traditionally performed by a non-cardiologist who might have only basic training in echocardiography, and advanced comprehensive echocardiography that is performed by people who are accredited and fully trained on echocardiography. But actually, the line and the split between both is getting blurred, because now we are witnessing an evolution of point-of-care ultrasound with the advancement of the handheld devices. Now we are seeing handheld devices with pulsed wave Doppler with continuous wave Doppler and even tissue Doppler. And we are seeing many non-cardiologists who are getting high levels of accreditation in echocardiography and point-of-care ultrasound. So this brings us into an evolution of point-of-care assessment at the bedside using ultrasound, and that will be the major aim of the presentation. This is briefly from an editorial which was published by Professor Bronwald and Professor Narula at the JAMA, and they called for adding ultrasound as a fifth vital sign. So adding insonation as another important extension of bedside physical examination. And that is the case that I'm going to demonstrate how we perform our protocol. So starting with this patient, 55 years old, came to us from another center with fever, increased inflammatory markers with worsening acidosis, hypoxemia, and hypotension. And he received lots of IV fluids before coming to us because he was obviously hypotensive. And that's the echocardiogram. You can see clearly that the biventricular function is reduced, the LV function is severely impaired, but we don't really rely on ejection fraction in the context of hemodynamic instability. And again, other views confirm that the LV visually looks significantly impaired. But we went forward and assessed the LVOT VTI because stroke volume evaluation is the reliable way to assess cardiac function and left ventricular function at the bedside, because ejection fraction has many factors which might interfere with its validity in critically ill patients and hemodynamic instability. And you can see here, this patient LVOT VTI was 8.3 centimeter, which equates to a cardiac index of only 1.4 liters per minute per square meter. So he was in deep trouble, he was in shock. And because we don't forget the RV, we always assess the RV to evaluate the pulmonary vascular resistance. This patient's pulmonary vascular resistance was elevated, which was evidenced by significant shortening of the acceleration time in the absence of significant tachycardia. And we went forward to evaluate the diastolic function and filling pressures. And obviously this patient had high filling pressures with estimated wedge pressure of about 20 according to the NAGA formula. But this is not the end of the diastolic function, because we also added lung ultrasound in the assessment of congestion. You can see B lines on your right hand side, coalescent B lines, so that would demonstrate alveolar edema. And on the left-hand side, you are seeing evidence of right lower lobar pleural effusion and consolidation. So you could understand now why this patient was hypoxic. He was congested, he had pleural effusion, and he was consolidation. So because he was in deep trouble, our provisional diagnosis was sepsis-induced cardiomyopathy. So we give him antibiotics, but he required immediate support. He was intermax class 1, crashing and burning. He required to be put on a peripheral VE ECMO and Impella to offload the LV, which was becoming overdistended by the peripheral VE ECMO. And after a few days of antibiotic therapy, the patient started to improve. The LV recovered. We were able to wean the ECMO successfully and also remove the Impella. And the RV also recovered quite well with improvement of the pulmonary vascular resistance. And you can see here, there was restoration of the normal pattern of A lines, which indicates resolution of congestion. But is it the end of the story? We used to think until very few years ago that this is the end of the story. We send these patients to the ward, to the high dependency unit, edematous, as survivors of critical illness. And they end up having abnormal renal functions from sepsis, and they go and they come back to us. And we found that these patients obviously develop longer hospital stay, longer readmission to intensive care unit, and some of them die without understanding what's happening on the systemic venous side. That's the importance of the new concept of trying to look at the systemic venous side and trying to understand what are the repercussions of focusing on optimizing the preload in patients with shock. So for many years, we were talking about the concept of preload responsiveness, which justified augmenting the preload as long as we are going to improve the cardiac output. But this has proved to be not entirely reliable, because as per this equation, you could see that rising CVP will reduce the perfusion of the organs. We tended to look at the CVP as the RV preload, but we did not to look at the CVP as the afterload of the organs. And that's the real trouble. And we have many data in the literature which demonstrates that the fluid excess and overly positive fluid balance increases mortality, increases incidence of organ ischemia and organ congestion, and there are many studies which demonstrate that. And this is actually an interesting study which looked at the incidence of delirium after cardiac surgery, and it was strongly linked to excessive cumulative fluid balance, especially after the first 48 hours of cardiac surgery. And when we tried to always think of fluid responsiveness, we only remembered the red curve, which is the Frank-Starling curve. But we should always also remember the Guytonian venous return curve. And they both exactly work together. So when you aim to improve the forward, the preload, to improve the stroke volume, don't forget that at one point you will reduce the forward flow to the organs, and you will increase the afterload of organs, and you will cause organ ischemia. And that's why the concept of fluid tolerance is more important than fluid responsiveness. But how do we evaluate fluid tolerance? Luckily, we only got 2 years ago a proper validation of this protocol by a team in Montreal, which looked at 145 cases after cardiac surgery. They assessed the inferior vena cava diameter, the hepatic vein, the portal vein, and the renal vein. And with this, they found that excessive systemic venous congestion, according to the score they developed, was strongly linked to incidence of acute kidney injury in these patients. And the protocol basically is looking at the IVC diameter, looking at the pattern of the hepatic vein, looking at the pattern of the portal vein, and the pattern of the renal vein. And it's not difficult to perform. You can do it equally from the subxiphoid approach or the transhepatic approach, which I prefer. And these are the different parameters which you can see and try to assess when you perform systemic venous ultrasound. The IVC should be less than 2.1 centimeters. So if it's dilated 2 centimeter or more, then you have to do the protocol. And I do it routinely in our patients, whether in level 3 or level 2 care. And if it's dilated, you go forward, assess the hepatic vein. If you see systolic reversal of the hepatic vein, that would be a strong indicator of significant systemic venous congestion in the absence of tricuspid regurgitation. And then looking at the portal vein, and the normal portal venous flow should be monophasic. Once you see pulsatility of the portal vein, as you can see here, that would be even more specific for systemic venous congestion as compared to hepatic venous flow. And the final part is the renal veins, which is slightly more challenging, but with practice you can also acquire it without difficulty. And the renal vein is under the baseline, and the more the congestion develops, the more pulsatile the renal venous flow will become, similar to the portal vein. And that is called VEXA score. VEXA stands for Systemic Venous Congestion Assessment with Ultrasound. So back to our patient, this is his VEXA score. He had dilated IVC, his hepatic veins showed systolic reversal, and his portal vein was more than 100% pulsatile. So his VEXA score was 3, which indicated that he was marinated and drowned in fluids. And we did that because we used to give fluids without thinking, and our surgeons, unfortunately, are very keen on giving filling, which is a dangerous word. And after offloading the patient for a few days, we started immediately to see improvement in the hepatic venous flow, restoration of the normal monophasic flow at the portal vein, and the IVC diameter became less than 2 centimeters. And also, more importantly, we saw improvement in renal functions, normalization in sodium level. And when we put together these concepts of echocardiographic assessment, lung ultrasound, and even advanced assessment of fluid of filling pressures, you can perform these parameters to evaluate hemodynamics, whether it is low cardiac output or shortness of breath at the bedside, to try to improve the quality of care we give to our patients. And I think this is a pyramid. So a pyramid of evaluation that will try to give you more ability to improve the quality of assessment and enhance your clinical examination. So integrated approach, it's all about adding these modalities together. It doesn't take time to perform the whole protocol. I would say it takes me about 5 to 10 minutes. It depends on how many parameters I'm looking at to get an idea about cardiac, lung, and VEXAs or systemic veins. So never forget looking at the lungs, never forget looking at the systemic veins. For many years, we were only looking at the heart, but this is not the full picture. We should not forget about the challenges. This is an evolving field, so we have to aim for better pathways for training, for accreditation, quality control, governance, documentation, medico-legal aspects. And also, as cardiologists, we have the obligation to supervise this because we are the masters of echocardiography. So we should be leading, and we should be helping our colleagues from non-cardiology to perform echocardiography safely, especially if they are pursuing advanced levels of accreditation and practice. But the main challenge, in my opinion, is the culture change, because people at the beginning might not embrace it. But now we are trying in our hospital to train the physiotherapists, the outreach nurses on basics of point-of-care ultrasound. And that's the way everyone will talk the same language and move together to understand the benefits of levels of accreditation in point-of-care ultrasound. And that's my take-home message. It's time to rethink our IV fluid strategy. I think fluids are drugs, so we should prescribe the fluid amount we want to give the patient. We should prescribe the duration. We should put a stop date on the fluids. Otherwise, we risk causing fluid intoxication and excessive fluid side effects. Point-of-care ultrasound, whether it is basic or advanced, should be thought of as an extension of bedside physical examination. And of course, in training and accreditation is very important. And I would expect that we will witness levels of accreditation in point-of-care ultrasound, where we will see level 1, level 2, and level 3 for those practicing, and always interpret these findings within the clinical context. And again, multimodal approach is much better for evaluating our cardiac patients, cardiac, lung, and VEXIS. And finally, of course, this is an evolving field. So we're hoping and aiming for more data and more validation and further research. And thank you very much for your attention.
Thank you so much, Hatem. Very eloquent talk. And I think people here might have some questions in mind. So is there any question, Dr. Firas?
Yes, thank you very much, Hatem. I also think this is an outstanding presentation. First of all, the culture change should involve the multidisciplinary approach to the complex cardiac ICU patients. Separating the intensivists from the cardiologist in rounding on very sick cardiac patients is the thing that needs to change. And the success happens when all of them are, with the surgeon, are on the bedside making decisions together, because the way you see things could be different from the way the other people see things, and having everybody together usually results in the best decision. I wish many people approach the intensive care, cardiac intensive care patients the way you do, because if you go to the ICU, routine ICU, there is always emphasis on two things. Number one, fluids, fluids, fluids. And of course, when it's a cardiac patient, especially a heart failure patient, this is really dangerous because it makes the picture significantly worse as opposed to better. The other thing is, and this is very common, intensivists say, keep the map above a certain number. They calculate a map of 60 or 65 as an adequate perfusion pressure, but the perfusion pressure is indeed the mean arterial pressure minus the venous pressure. So if you have a heart failure patient with a CVP of 20 and their map is 65, their net perfusion pressure is in the 40s. So, and that's of course not going to result in organ recovery. If anything, the literature, like you said, is suggesting that cardiorenal syndrome is commonly because of, more importantly, because of venous congestion than low cardiac output. This is very established in the heart failure literature now. So I congratulate you on this work, and I think it will go far.
Thank you, Dr. Firas.
Okay, thank you very much. Very nice talk. Thanks for staying with us till this time. And Dr. Magdi Abdelhamid, the final closure points and take-home message.
So now we finished the excellent 2 days meeting. I'd like to thank you all. I'd like to thank all speakers and chairpersons. The sessions were excellent, interactive discussion. Speakers presented very interesting presentations. I'd like to thank the all board members of the HFA, ECC, Professor Rosano, the president of HFA, for the excellent collaboration. The meeting was in collaboration with the HFA ECC. I'd like to thank all board members of the Egyptian Society of Cardiology, the Working Group of Heart Failure. I'd like to thank all pharmaceutical companies who supported this meeting, and they had an excellent contribution for the great success of this event. Novartis, AstraZeneca, Bayer, Boehringer, Servier, Apex, Adco Pharma, October Pharma, Global Nabi, Biofactor, Marcare, Inspire, El Isra, Habib Scientific Office, and Eva Pharma. I'd like to thank the distinguished experts from different countries, Arab region, in HFA board members. Finally, I'd like to thank Dr. Ashraf Badawi, IRIS team, for the excellent organization. I hope that the meeting was at the level of the expectation as every year, and I hope to see you all next year in another city, another venue, and thank you very much for your contribution to the program. Thank you very much.